I'd like to welcome you to the introduction to the Pettibon weighting system for spine and posture correction. I want to stress that this is a basic introduction. My name is Dr. Roger Elmer. I run Advanced Neurospinal Solutions. I've been doing the Pettibon system for the last 17 years. I'm a fellow in the International Chiropractic Scoliosis Board, and I'm a diplomate in the American Board of Chiropractic Neurology, and I'm also a functional neurologist. And so when I start every Pettibon class, I always start with how I describe Pettibon system, doing the Pettibon system, and it's always the same word. It's always adventure. For me, doing the Pettibon system is an adventure every single day because every patient is different and every patient is different every day. We're creating changes throughout their system, throughout their body, but we're also changing their lives. That phrase is thrown around these days. That thing changed my life. They're actually, it's rare to have a life-changing experience. But I see it all the time in terms of changing the system and changing the body. Now, we've already gone through the model in one of the webinars where we talked about the Pettibon normal model. We discussed in detail the value of normal. What is it about normal that makes things work so well, and why we spend so much time developing that system as infants and as toddlers and as children, developing that system from so many different angles. We talked about biomechanics, and we talked about neurology and development of the spinal cord and brain stem. We talked about the development of the brain itself. And I discussed how vital that concept is and the contribution that Burl Pettibon made to the understanding of what normal is, and it being one of the most important things in the Pettibon system. I want to stress that Pettibon system is not a technique. It is a system. Now, there is an adjusting technique within the system, but it's an entire system, and we're going to discuss a little bit more about its completeness in a little bit here. But today we're going to be discussing the vehicle for taking structure, the spinal system, which will also include the legs and feet, and changing it. And the vehicle for doing that ultimately is the weighting system. And what's really fun about this system for me is that it makes changes that are predictable, that are dependable. And in fact, one individual, Dr. Carrick, is on the functional neurology side of what we do. He said that he was asked about the changes that are being made, and he says that they look like miracles. And he says, well, they look like miracles because most people can't explain them, but because they happen so regularly, they've become a clinical expectation. And these are things that we can clinically expect, and especially we can see beforehand using X-ray to weighted X-rays to determine, is this going to be helpful for the patient, which is very, very exciting. And so I live in a different world, a world where we can expect changes, but also patients get changes. And because they're getting changes, because their lives are different, almost 100% of my patients come from my patients, because their friends, the friends of my patients, see them changing, see them walking differently, see them living a different life, see them getting into sports or activities that they couldn't do, and they're saying, hey, what's going on? How do I change myself? I have been out of work for 5 years or whatever. And so being in this kind of work affords that kind of life where I don't advertise. I mean, the people come to me looking for me because of the reputation that is created by the consistency of this change. Now, the Pettibon weighting system works. So you just saw a picture of the head weight, the shoulder weight, and the hip weight, and it works with the reflexogenic system rather than working against it. We're going to talk more about that in a few minutes here. The system, the nervous system that controls your body has two sides to it. It has a voluntary side and an involuntary side. And the Pettibon system activates both of those, but particularly what makes it so exciting is that it activates that involuntary side of the system. In functional neurology, one of the things that we say is that the neuraxis is sensory driven. The brain and the spinal cord, the brainstem, they all respond to inputs that are coming from the outside, either the outside of the inside of our bodies or the outside world. And this works with that system in creating that stimulus. Reflexes are at several different levels. You've got reflexes in your spinal cord, you've got reflexes in your brainstem, you've got reflexes that you develop into the basal ganglia and into the brain itself. And the basic concept of a reflex is that the receptor, that you have a receptor, that you have an afferent nerve, and that it comes up into the central nervous system, and then it loops back around and creates an efferent effect or a motor impact on some kind of end organ. And the brain really only does two things. And this is from neuroscience. The two things that the brain actually motorically or motor-wise does are to contract muscles or secrete stuff. Everything else that the brain does is a product of those functions. The brain receives information from the outside world, receives information from our inner world, takes that information and collates it all and creates the world on the inside of our brain, and then decides how to respond to it, and that's our motor effect in that. But that concept of the receptor, we have to think about, of the reflex, we have to think about that kind of system, because we want how we're changing the spine to affect those reflexes, not just the voluntary activities that potentially can do some of that work. And so we want to affect the spinal cord and the brainstem, and that, which we'll discuss in a few minutes. So you can imagine we're going to call this system of reflexes, we're going to call it a reflex system that we can wire in and count on. And so imagine if you cut the head off a chicken, the chicken flops around and flaps its wings and pretends like it's breathing. None of those things were produced by the brain itself. None of those things were actually produced by the brain stem itself. They were wired into the spinal cord. And so these effects we want to wire into the into the spinal cord and brainstem, so that we have this ability to do it without thinking. It's in the involuntary system. The pieces of this system include the labyrinthine system, which is in your head, you got the semicircular canals, you got the otoliths, which include the utricle and saccule. And when we discuss the ability to control where your head is in space and to experience gravity, which we spent some time on in the model where we discussed that the two most important stimuli on our bodies are gravity and breathing. And that the breathing mechanism gives us inputs to the brain to keep it awake, alert, and alive, but also gravity. Gravity pulls down on our receptors, including the labyrinth, particularly the saccule, and it does have an effect on the utricle. Minimal, brief inputs to the semicircular canals, but they create an input to the vestibular nuclei and then into the brain and keep the brain awake, alive, and alert. Well, that labyrinth is a vital part of our writing reflex sensory system and inputs into the sensory and reflexogenic response to gravity, so that we have the proper tone not only to stand against gravity, but when we start to walk, so that then we have the proper tone to create the turning on and turning off of those muscles that need to be activated and need to be worked in a very rhythmic way so that we can ambulate. These reflexes can be boiled down into very specific, definable reflex systems. We tend to talk a lot about, in the Pettibon system, the 5 writing reflexes. We already discussed the labyrinth, and we know that it's in the medulla, a little bit in the pons, but mostly in the medulla, and the receptors in the inner ear, and that we're responding to gravitation and head orientation. The optic reflex, we're using it also to orient ourselves, because there is a reflex that wants our eyes on the horizon, and we want to make sure that it's on that horizon, so that our bodies can function properly and effectively against gravity. Also, we have a large amount of nervous system input from the neck, from the muscles, and from the joints, telling us where that is in space, working very hard to keep our head on top, to keep our uppermost. And then we have a couple of body writing reflexes that work together in terms of orienting the head to the body and orienting our body in space. And we even know where those are, particularly within the midbrain, within their neuronal pools and that. So, but in defining those areas, we want to create an effect of working with that system, all the parts of that system. In this slide, we talk about the effect that muscles have on our joints themselves, and that they are the primary stabilizers, and that the tone that comes, the involuntary tone that maintains that front to back, side to side tone of the muscles themselves, the spike trains that keep those muscles at their specific tone, come from an involuntary system known as the vestibular nuclei. Now, in discussing the weighting system itself, and within the Pettibon system, everything that we do really is about the weighting system. All the other functions, all of the things that relate to causing instabilities within the system to become stable, shortening muscles to do that. When we talk about changing the shape of the discs, which we'll spend a little bit of time today talking about, we're always doing it so that the weighting system will have its maximum impact to restore the structure of the spine as close to perfection as possible. The cool thing about this is we're using a principle in everything we do. That principle, the underlying, undergirding principle, foundational principle, is adaptation, the law of adaptation. We are getting the system to adapt, to change, to adapt by putting stimuli on the body itself. When the head is forward, and the patient has all of the things that come with head forward posture, which have already been defined in the literature, by the way. We have a lot of literature and research that already defines some of the many things that can happen as a result of that, and we're not even discussing all of the parts that make standing up against gravity a problem. We're talking about the actual things that relate to symptomologies here. When the head is forward, if we take and put a weight, let's say we put a pound on the forehead, it actually causes a destabilization and that destabilization brings the head forward, disrupts the ocular vision of that horizontal plane on the horizon. It destabilizes the labyrinth, particularly the utricle. Initially, it can do the canals, can do the anterior canals, but it's going to be more utricular and saccular in nature. It's also going to cause changes in pressures, centers of pressures within the muscles and within the joints, causing the system to have to respond in some way. It's also going to affect the body writing reflexes and the pressures and orientation of the body. And because of that, because we're creating that stimuli, it's forcing the system to have to adapt. Now, if you put a lot of weight, obviously it can react. Now, when you think of reaction, somebody takes medication and they react to it. That doesn't sound very good. But if we say, what if they were to respond to that? Oh, that's a lot better, isn't it? We want to put the kind of weight that will cause them to respond to that weight and cause the reorientation of the system through the law of adaptation. We get them to adapt into that new position. And as they do that, they're playing right into our hands, right? This is now called therapy. We're going to change all those things through that system. Notice now as the head came back, but the skull didn't come down. Now, if you were to have a physical therapist, and I had a buddy who was a physical therapist, and he said, well, which muscles would you work? And I said, well, we want to work the muscles that are in the back here for sure. We want to do that, but then I want to work some muscles way up here to get the head to come back so that it has actual ability to bring that head down and to have it down before. If I didn't work with muscles back here and then I did work with muscles up here, I would wind up maintaining the same problem that I had. And I said, and I'm just dumb enough to not know how much of each that we need to recruit, what level of neuromuscular recruitment pattern needs to be done and all that. So I'll just let the patient's brain and brainstem figure it out. And so when we put the weight on, the head's going to come back, the neck's going to come back, the head's going to roll back, and then the eyes are going to come down because it's going to activate the proper musculature to get that done, but it's also going to activate the neurology to do the appropriate amount of that muscular activity. Then it's going to stimulate the adaptation as the patient is wearing it twice a day during the therapeutic regime that we're going to perform. As they're wearing it, it's stimulating changes in all of the effects, and we're going to go over that in just a second here. So in here, we're seeing that head come down, and that from the response to the weight itself, and we're stimulating it through putting the weight on the outside. Now, here we have a person with a head forward posture, and this is what it looks like with the weighting system on. She is responding to that. Her head is coming back, and there's a reordering or a reorganization of the tissue that's on the inside of all the effects, and we're going to discuss that right now. This is what we call the Pettibon change model. And I really want to stress, if you can learn this, if you can get a vision of this, you can begin to think with this. And instead of being a technician in the Pettibon system, instead of being a cook, you can learn to be a chef. You can start thinking with this stuff and becoming very, very astute at doing finite changes, not only directing them in what I call a surgical approach, but also you can be subtle in your approach and changes. There are 3 tissues that have to change in order to affect a change to the structure. The bones are fine. Sometimes you'll get, in the more difficult cases, you get fractures that even though they're healed, that change the shape of the bone. Sometimes, rarely you're going to get genetic changes, and we do this a lot. Dr. Morningstar and I work a lot with scoliosis cases, and in the ARC 3D system, and that which is basically a modification of the Pettibon system using the same principles. In fact, you're seeing it here, the basic foundational principles of what we do in scoliosis. But it's not the bones themselves that we have to change. We can't. We're going to change the tissues that support them, that are between them, and that drive them. And so those tissues are white tissue, red tissue, and neural tissue. Now, in white tissue, it's fibers, particularly discs, ligaments, fascia. When we're dealing with scoliosis, there's a lot of fiber that has to change throughout the body, including like the chest cavity has to change, and the fibers that hold it together because they're torsion. And so we're going to be changing that. And it's like orthodontics. There is a change in those fibers where we're going to elongate them without tearing them. There are systems that actually do work to try to get that tearing. We do not want that. This is the effect of a tear, and it's pathological. It creates instability. It creates a weakness that the patient can get injured further in the future much easier. We are not trying to achieve permanent plastic deformation. That's what this is. You get it in a car accident, and you get it with harsh traction without warming it up, but also just plain harsh traction over time. You can tear that. We're trying to take this fiber and change it over time. Some of these fibers need to get much longer. When we talked about this in the model, in the understanding of the model, that in order to put a lordosis in the neck and lower back, we got to have wedge shape to the disc, where it's bigger in the front than it is in the back. So three-dimensionally, these millions of fibers have to change. Then we have to pump the fluid back into the disc so that it becomes stable from a hydraulic property point of view. And we learned the engineering to that we're loading the disc so that it becomes very, very strong and very stable. The next one is red tissue. And red because it's got blood. And so we talk about muscles, but we are not interested in what everybody else does. That all the exercises where we're using our brain, and particularly using our voluntary system, the pyramidal nervous system, drives the type 2 fast twitch phasic muscles. We're not interested in that. In fact, there are three journal articles in Spine since 2006 that discuss that traditional therapies that use the brain and surface muscles of the pyramidal system, which is traditional therapies, including physical therapy, exercises in chiropractors' offices, and including the personal trainers are using that system. And I'm not trying to be negative on it. This is just the function of the system. We don't want to rehabilitate this system utilizing that approach, because it will relegate, and this is what it says in the journal article, it relegates the involuntary to the voluntary. And so it says, even though you may have a decrease in symptoms and pain, the chronic back problem persists because of an abnormal neuromuscular recruitment pattern, because now it's relying on the voluntary system rather than the involuntary system. And the Pettibon system works very carefully to modify that involuntary system. And the weighting system is one of the primaries to make that happen. So we're working with the type 1 slow twitch muscle fibers, and in it they're very, very difficult to work with. It takes a long time, a lot of effort. It takes a long, slow approach rather than fast, which you can get some pretty fast, quick results with voluntary muscles. If you've ever been in sports and want to build up fairly quickly, you can do so very, very rapidly by comparison to the slow twitch stuff. But the cool thing about the slow twitch stuff is once you build it up, you're using it every day, all day long, so you don't lose it very fast. And if you're pushing it just a little bit, you can maintain it. We're also we got to change the neural tissue, and we're not using the brain in this, the pyramidal system. We're using the brainstem, cerebellum, and the extrapyramidal nervous system. Now, in achieving this change, the cerebellum is connected within the extrapyramidal nervous system, and we look at it as like the COO, the Chief Operating Officer. The brain decides what to do, but the brain stem and the cerebellum are the ones that make it happen. And the cerebellum is attached to the extrapyramidal nervous system, which is the involuntary nervous system. It's not the brain you think with, it's the brain that thinks you. It's the one that holds you up. It's the one that modifies all your activities. But also, it's attached to several tracts, including the reticular tracts, which are your sympathetic and parasympathetic nervous systems that make sure that you have blood flow to supply the activities you're asking it to do, so your muscles and nervous system can cash its checks that it's writing. And it also runs the recovery systems, which include making sure that parasympathetic nervous system engages so that you're recovering, and is also a part of that recovery system that includes sleep and sleep patterns within that reticular system. And so we're working with all of that within the system. And so when we look at this model, we can begin to think about those changes in terms of how are those changes going to be affected. When we look at the white tissue and the neural tissue, we're going to be working to change the shape of the spine so that it no longer has pressure on the cord. And we talked about this in the normal model, that when you have those curved systems, according to Alfred in his monograph, Adverse Mechanical Tension on the Central Nervous System, which we quoted in the other module, that having those curves makes it so you have no pressure, no stretch on the cord. And this is really heavily relevant, too, when we start talking about scoliosis, because it's not just a stretch. The scoliosis is an adaptation to avoid that tethering, that stretching, which we call functional stenosis, on the cord and improve the blood flow, but it still creates an asymmetrical pressure on the spinal cord, to where on the inside of the curve you're stretching the cord widthwise, and on the outside of the curve you're stretching it depthwise, which has a radical impact on the blood flow within that cord in that relationship. And that's currently something that I'm working on in a master's thesis relating to neuroscience, neuroscience of scoliosis. So we want to change the sagittal plane. We want to change the structure of it. We want to orthodontically change it. We want to get the red tissue to change. We're also going to be using the red tissue as a sensory input to change, to repattern or re-engineer the system so that it functions this way, and it has its wiring. Remember, we talked about those reflexes. We want them to function without our actual conscious input. We want to be able to walk and talk. If you're walking in the woods with somebody and talking, you don't want to have to stop talking to them so that you can keep walking, even if it's an uneven surface. Within Pettibon's system, we are going to be working to repattern and reprogram all of this and make sure that the brainstem, cerebellum, the spinal cord, and the extrapyramidal nervous system are all patterned so that they take care of those things for us without thinking. We're also going to be working to make sure that we have the proper amount of stability versus mobility. If you have If you have stability with very little mobility, we call that degeneration, right? Lack of activity. And that's not only disastrous to the joints, right? What was the study that was done with rats where they took and locked the hip joint, and where it couldn't move, and then they actually looked at the surface of the joint, and in 4 hours under a dissection scope, there was visible pocking due to lack of nutrition to that joint. So one of the biggest components of degenerative arthritis, osteoarthritis, is lack of nutrition. And we don't think of it usually that way. We think that it's degrading. Well, if there's any degrade in DDD or DJD, it's because of lack of mobility, which leads to that malnutrition to the joint, and therefore it's dying of malnutrition. Okay? And then if you have all stability, or little stability and all no mobility, we call that instability. And it's either ligamentous instability due to injury, or it's hypermobility because we've got abnormal tone supplying or supporting that joint, causing it to be very, very unstable. Over time, it will create its own stability, which we call degenerative spurring and then eventually fusion. If it doesn't get the job done, it will get it for you. It will go ahead and fuse together. We want an even blend of stability and mobility. And so you have just seen a very, from the 10,000 foot view of the Pettibon system, what we're trying to accomplish in that. In dealing with the Pettibon system, because we're dealing with the head, because we're dealing with the head, we're dealing with a living system. We're going to describe it in terms of in vitro versus in vivo. In vitro means under glass. In vivo means in life. Whenever we cut off the head, either in our analysis or in our approach, we're cutting off a major portion of what makes this entire system works. I've never personally had a patient come in without a head or leave without a head. We've got to figure that into the equation of the rehabilitation process, because the majority of the information that we use to determine where we are in space and keep us upright versus gravity is up in the labyrinthine in the eye system, and the brainstem receives that information, the vestibular nuclei, and depends upon it. It's also receiving input, like we said before, from the neck receptors. And that. So not only is our analysis astute at finding that information of where is the head in space consistently, but also our approach in putting weights on the head, we are orienting the person to gravity, and so that it can be where it's supposed to be, and so that the body can follow suit. And that's really what we're trying to do, to get the head on top, to get our butt underneath it, to get our body underneath it in 2 dimensions, and then put those curves back in the lower back and neck, and we're doing it with all 3 of the tissues, and then we're going to get it to change over time. It's going to reshuffle itself. We discussed the functional units within the system. It's not 24 pieces parts. It's actually the lever system where actual units work together into a stick or lever system, which gives us not only the ability to move those as sticks, but to give us leverage factors, force multiplier factors. What does that mean? It's like a machine. We did talk about the concept of machine. We put something in, we get more out. If we put a quarter in a machine and we don't get a quarter out, we call that government. If we put a quarter in and we get 5 quarters out, that's a pretty good machine. If we put a quarter in and we get 10 quarters out, that is a much better machine. And we want to restore the system as close to its design so that it gets the maximum output from the minimum input. We want to change that system so that it functions that way reflexogenically, so that it leaves us with the capacity to do other things. And in doing that, we're causing the change of the system autonomically at the same time, so that it can function the body, so that it can cash the checks with the sympathetic and parasympathetic nervous systems and the recovery systems, and so that it will stop the degrading. Because every one of those patients that comes in, especially the more you do Pettibon, the more you're going to get the really difficult cases. They're going to come in, they're broken down, but they're also having all kinds of other problems, some of which they're not going to tell you. And you have to be astute enough to ask them all the things that are going on. They're seeing 10 different doctors. They're seeing, and most of those are specialists in that. And so you need to ask them very specifically all the things that are going on, because they'll give you clues into what areas are breaking down, and what area has the greatest impact on their symptomology in that. But ultimately, it is the system that's going to make it happen, not your adjusting. Your adjusting is just to stimulate the nervous system to get it to be able to stand up a little bit better, but also give it the mobility for the weights. It's all in the weights. So we're going to create a reorientation causing temporary changes in the skull, the thorax, and the pelvic center of mass. But then we're going to apply this therapeutically, causing those changes. And it's through the sensory system, that sensory feedback system, that we're going to make that happen. But we're going to create a patterning within the involuntary nervous system to make that happen. Now, in the weighting system itself, some basic concepts that I want to get across. We'll be going through advanced rules and in future modules, advanced weighting modules in that. But the two most basic principles that I want to get across is, number one, you are weightophobic. The person is weightophobic. They move away from the weight. And then I'm going to give you the girdle rule, the pelvic girdle, the shoulder girdle. What if we were to weight a girdle, like let's say a shoulder girdle, you got a low right shoulder, and let's say we put a 1 pound ankle weight on that shoulder. The patient is going to lift against it. And you see this every day, especially if you're married, and your wife puts the purse over the shoulder and that shoulder comes up. And that's literally how the weighting system came into being. Dr. Pettibon was watching a guy who had a high shoulder in an airport, and the guy reached down with the other hand and picked up a heavy briefcase, and it leveled out. And he said, "Hey, that could work." And from that has come this amazing three-dimensional system that we use now to very specifically and very strategically cause the system to adapt in better and better postures, and to cause it strategically to reorganize itself and to reflex that system so that it functions that way without you having to think about it. Very cool stuff. Okay, and so we're going to be looking at the patient when we analyze them. We're visually, but we're also going to be taking x-rays, and they're going to be taking x-rays with the weight on. That is how we're going to test it, and the cool thing is once you see it, it's going to bring confidence. If you put a pound on this patient's head, if their head is forward 2 inches, well, if their head is forward 2 inches, imagine if their head is 10 pounds. And if that 10-pound head, if every inch forward is another head weight or another 10 pounds, that patient now has a perceived weight of 30 pounds on that head, which makes it difficult to hold up. So, and then you put a weight on, and it comes back an entire inch. So now it's 2 inches. Okay. Well, what does it weigh now? Perceived weight. Now, many of you are going to say, well, now it's 20 pounds. No, actually, we changed the weight of the head, so it's 11 pounds. So we double that, and it's 22 pounds. but we've knocked 8 pounds off of that just by putting the weight on, and that is their therapy, and we see it. It is actually working. Like I said yesterday on a patient who just signed up with me yesterday, I threw up the x-ray, and I said, take a look. You were 2 1/8 inch head forward, and now you're down to 1 1/3 inch. Okay. Is this going to work? She said, well, it looks like it. I said, it is. It is right now. Now, I don't know how long you're going to be able to wear it because you have scoliosis. We're going to keep it within your metabolic capabilities, within your capacity to wear it, but you are going to be able to use this, and it's doing the job we asked it to do. And that's what brings such great confidence in standing before the patient and saying, yeah, this is going to work. This is going to change your structure in that. So we're going to put that on, put the weight on. We're going to take an X-ray, and if we see that it works, we're going to do it. And if it's not, we are not. It's cold, hard math. If it makes the patient worse, they're reacting to the weight. And so the system that I've designed, I always start very, very light, and we'll discuss that in advanced modules. But we want to analyze and know for surety that it's going to do the effect that we're asking it to do. Okay? Here's somebody wearing the weights and using this amount. I'm not sure that they're going to be able to tolerate it for the full 20 minutes. Some will, many will, but the longer you go, the more you're getting patients that are weak and ready, and you may have to be careful. We use a pulse ox in our office, especially with the weaker patients. All our scoliosis patients wear a pulse ox. It's more important than the timer, because if they neurologically, if the O2 saturation goes down and the heart rate goes up, that is ding. They're done for that session. So this is what a shoulder weight looks like. It's to create an effect of lift and possible rotation. If we think about it, like that ankle weight that I talk about with the girdle rule. With the ankle weight and the girdle rule, if I take and put 3 pounds in this shoulder weight, and I take and I put a pound in the front and 2 pounds in the back, the pound in the front combines with the pound, a pound in the back, and creates 2 pounds of lift on that shoulder. And it's got to do that along with that extra pound that's in the back, or weight-ophobic with that, which creates a rotation forward. So we're going to rotate forward away from that extra pound. So we get 2 pounds of lift and 1 pound of forward rotation on that shoulder. So if we divide it up that, it makes it a little easier to understand. Now they work, the head weight, the shoulder weight, and the hip weight work according to the innervation of specific muscle groups, and that, which we talked about in the normal module, and that the head weight works from the head all the way down to T7, whereas the shoulder weight works from the shoulder position all the way down to L3. So the primary muscle there is the latissimus dorsi. And then the pelvis works with unit 6, the pelvis and sacrum, and has an impact also on the lower carriage, the muscles of the lower legs, the muscles of the legs, in order to respond to create that effect of the pitch angle of the pelvis or the lateral shifting of the pelvis, and we'll go over that in the more advanced modules, describing how the hip weight does what it does. And what's really funny is you put a hip weight on, and it changes basically L5 down, and then if you watch on the X-ray, it forces changes above it, but those are all as a response of the changes in the pelvis, which is really, really cool to watch. It's creating, when we put some of these weights together here, we're putting a head weight and a shoulder weight. Notice how when the head weight is rotated against the shoulder weight, rotated the opposite side, they begin to work together in what we call a coplanar contraction, creating not just the head coming backwards, but creating a rotation. We're rotating away from the weight with the head so that it rotates forward. So we get rid of the yaw. We call that yaw in neurology, particularly when we're discussing vestibular stuff. It's a nautical analysis. So we're getting rid of that. We're getting rid of some of that yaw and getting the orbit straight forward. That'll have a lot of meaning to functional neurologists in terms of causing that system to rotate so that we can have a more perfect presentation of the not only the orbits but the utricle and the saccules, and so that they have their optimal expression. The shoulder weight creates a lift and a rotation, and so those muscles are working with themselves and torquing with themselves. If you've ever seen a snake torquing about itself, that's that kind of impact that we're creating, because the spine is really more like a cylinder. These multi-dimensional strategies work not only from the top to the bottom, but they're affecting, in neurology, we call it the homologous system, which connects the top to the bottom, but also the homolateral system, which connects the right to itself, the left to itself, and the ability to create a contralateral connectivity, which is what the cross-crawl and gait system in the adult system really is all about. And so we're able to do that and support it and to create the reflexogenic side of that, which is just absolutely exciting in its scope and what it can accomplish. This corrects, we need to make sure that we correct the cervical lordosis, and in the advanced models we'll present how to actually work strictly with the sagittal plane to restore it as close to perfection as possible. But right now we're focusing on the three-dimensional concept when we cause the lordosis to get within 60% of normal, we are causing it to become very, very stable, because the joints begin to meet together and the discs begin to perform their job and creating that spring mechanism biomechanically and all of that. And so we're looking to get that effect so that we can have it stable in the sagittal plane, which will make it stable, more stable in the coronal and the coronal and transverse planes, and we talk a lot about that in the advanced model, and we talk about it a lot in scoliosis. So because when the system goes awry, it creates a corkscrew mechanism, which in its worst form is scoliosis. So, but we're going to be working with the shoulder, hip, and the head weight to make these kind of effects happen, and the pelvic mechanics become stable through the hip weight itself. So, and here we have reordering and reorganization of that system by using the weighting system. Here we show affecting that forward body system with that. We can also use the hip weight to create the pelvis to come forward or go backwards as we need to. Here we have somebody who's butt back. We can have somebody who's chasing their zipper down the street with their butt forward. They usually have no butt. Kind of like my father-in-law. His Indian name was butt fell off, but it's because he's not using his glutes. It's not rotating in position to allow him to activate those. He doesn't need to, and so we're going to be changing those by changing the pitch angle of the pelvis. So here we have a reordering, a reorganization, reflexogenically. We're getting the intelligent system to remodify it through adaptation. We're getting it to adapt into that posture. We're changing everything about all those three tissues that we talked about. We're causing the muscles to improve in their strength, to become symmetrized, to become the proper length that they should, to have the proper tone that they should have, to have the proper reflexogenic response to gravity and life. We're causing an increase in mitochondrial uptake, because if you're changing a muscle, you're changing the structure of it. It's like a Ferrari, right? You remake a Ferrari, it got banged up. You remake the outside, it doesn't make any sense to leave a VW engine inside of it. We want a Ferrari engine inside of it. So we want to increase its mitochondrial uptake. We want to increase angiogenesis so that the blood flow system is improved, so that it can support that system. We want the nervous system, which is the brainstem, cerebellum, and extrapyramidal nervous system. We want that reticular part of that system to be able to modify. We want the extrapyramidal nervous system to drive it without us thinking about it. But then we want the reticular, autonomic, sympathetic, parasympathetic nervous system tracts to give the proper input to supply the activities that are happening. Okay, and so we're creating an internal reordering or reorganization through therapeutic adaptation response. Okay, here we have some information relating to what we talked about before. Here we have the butt forward in that. So in terms of hip weighting, we're going to spend a lot more time in the advanced models talking about hip weighting and what it does. Here we have it on the left anterior, right posterior, which is going to create a strict rotation. And we're going to talk about how to change the sacral base angle using this. We're going to talk about changing the sacral base angle in the coronal plane and the sagittal plane, the pelvic line. We're going to talk about changing that with the hip weight strategically, and that. And we'll go on to the next one. These are the posture patterns, and we're going to progressively change these postural patterns from a number 3 posture pattern to a number 2, and then from a 2 down to a 1, and then from a 1 down to a 0. When you think of these postural patterns, think of a response to bad mechanics. So if we have bad mechanics, we don't have, and we have a healthy response, we have a zig and a zag throughout the system. It's trying to keep our eyes level with the ground, trying to keep our pelvis as level as possible, but it's trying to zig and zag and keep that postural position where we're actually, the posture looks like we are normal. But when you look on the x-ray, they're not. If I zig, I zag. And if I zig 5, I zag 5. Whereas with a postural pattern 2, I'm not quite balancing the way that I should. And that I may zig 6 and zag 3, and that. With a postural pattern number 3, we're zigging and zigging and zigging and zagging and zigging and zagging, and there's no balance to the system. It's very unhealthy. Imagine if you drank some poison. A healthy response to drinking poison is to feel ill and to vomit, to get rid of the poison. We often say, well, I drank poison and I got sick, and then I threw it up. No, that's healthy. Healthy to feel sick, healthy to up elevator, healthy to vomit. A type 3 posture is a completely unhealthy response to bad mechanics. I have these bad mechanics and I'm not responding to gravity well, and I'm breaking down. Type 2 is, posture 2 is, I'm somewhat responding to gravity. I feel the nausea, I'm up elevator, but it's not coming all the way out. Whereas type 1 is a healthy response to bad mechanics. It's still bad mechanics nonetheless, but it's a healthy response. I'm zigging and zagging equally in that. So that's how to think about it. In the loss of the cervical curvature and that, we get all kinds of corkscrew matrix configurations that we be reordering back. So we want to make sure that we're getting the sagittal plane back to the way it should be. The reason for Pettibon over the last 4 decades is to deal with all the chronic changes that happen as a result of structural change. We get modifications in the white tissue where the fibers are not the same as they should be. And that we get red tissue that we say, okay, that it's atrophying. And we tend to think that, oh, it's the muscles. Well, frankly, it's also the nerves. The muscles are atrophying, but we know that from breed that that asymmetrical change on the pressure on the spinal cord affects a change on the nervous system that affects the IML, which is within the spinal cord. That IML is making it so that we don't get the proper sympathetic response, which gives us our blood flow. The concept of atrophy, we tend to always think of, well, it's getting smaller. That's not what it means. Atrophy means no nutrition. It's not getting any nutrition. So we got to get the nervous system without the pressure on it so that the IML can express itself the way it's supposed to, so that we can get the proper blood flow, so that we can restore it. Now that means we're going to have to build those muscles up, and that's the essence of Pettibon system and ARC 3D systems for scoliosis, is we're going to put those muscles to task, but we're going to put the nervous system to task first to build it up. But before we do that, we're going to get the pressure off the cord so that it no longer affects the IML's ability to express itself. Okay, now here is a pre-X-ray with no weight, and here it is a pre-X-ray with 3 pounds of weight. Pretty cool, huh? And with this, it's causing it to reflect into a curve, which is really what we eventually want. With a lot of patients, you're going to get, it's going to take a long time to get that curve, and we're going to help you understand it better. Okay? And here it is. There's another one with a curve. Here's another one with a curve. We're trying to get the reversal of the curve to undo here, and we at least got it straightened there with weights. Here's a pre and post X-ray on the lumbar spine. Very cool. And in closing, I hope that you see particularly the elegance of the Pettibon system and working with the creating these structural changes and the global effect on not only the mechanics but the nervous system. Thank you. Bye.